Welcome to the deep dive. You know, there are some conditions that seem, well, almost mundane because they're so common, but often there's a lot more going on. Today we're diving into one of those.
Candidiasis.
Exactly, and it's a perfect example. Candidiasis, basically it's an infection. It's triggered when Candida fungi grow too much. Usually it's Candida albicans, that's the most common culprit.
Right.
But what's really key, I think, is how varied it can be.
Yeah.
You know, it ranges from just a bit of skin irritation, maybe, to something much more serious, like getting into the bloodstream.
So it's not just thrush, although that's definitely a big part of it, isn't
Oh,
it?
absolutely. Thrush is a classic example.
Yeah. And I bet many of you listening have either had it yourselves or know someone who has. So our goal with this deep dive is really to give you a solid, high-yield understanding. Think of it as condensing your revision notes for the MSRA, but hopefully a bit more engaging. Yeah, absolutely. We've got a pretty comprehensive set of notes here. We're covering the definition, the causes, the etiology, risk factors, how it actually works in the body pathophysiology, what else it might look like, so differentials, how common it is, epidemiology, the clinical features, you know, what you actually see, investigations, management, prognosis, and importantly, complications. So yeah, everything you need for a good review.
Okay, brilliant. So let's kick things off. Can we just nail down that definition first? What exactly is candidiasis?
Okay, so at its core, it's an infection caused by Candida species. And like we said, Candida albicans is usually the main one. These infections can be localized, so staying put in one area like the skin, mouth, genitals.
Right.
Or they can become systemic, and that means they've got into the bloodstream and can spread. The big difference, really, is severity. Localized is usually manageable, annoying perhaps, but manageable. Systemic can be, well, very serious.
Okay, so Candida isn't something we necessarily catch from outside then.
Yeah.
It's already living with us.
Precisely. That's a key point. Candida is a normal inhabitant. It's part of the natural flora in our mouth, on our skin, in the GI tract, the genitourinary tract. It's just there, usually coexisting peacefully.
Oh, okay.
And the common examples people know, like oral thrush, vaginal yeast infections, those rashes and skin folds, they're all examples of localized Candida infections, where it's just overgrown in that one spot.
And what makes it overgrow? What tips that balance from peaceful cohabitant to, well, troublemaker?
Right. That's where risk factors come in. Anything that weakens the immune system is a big one. Think HIV, diabetes, taking immunosuppressant drugs. That definitely increases vulnerability.
Makes sense.
But for the more common local infections, the triggers can be simpler. Things like a disruption in the normal microbial balance, maybe after antibiotics, hormonal changes like the estrogen surge in pregnancy, or even using steroids. And interestingly, moisture is a big factor for skin infections. Think about nappy rash or infections under burns. That damp environment really helps Candida thrive.
Right, that makes perfect sense. A local overgrowth because the conditions changed. And you mentioned systemic infections earlier. How does it go from being just, say, in the mouth to spreading everywhere?
Yeah, so systemic infection happens when a local infection breaks through. It gets past those initial barriers and enters the bloodstream. Once it's in the blood, it can travel pretty much anywhere, tissues, vital organs. It's a much more serious situation, and it's much, much more likely in people whose immune systems are already compromised. They just can't contain it locally.
Got it. Okay, so we've defined it. Let's dig into the why a bit more. The etiology. What are the specific causes driving this Candida overgrowth?
Well, the fundamental cause, as we sort of touched on, is that disruption of the normal balance. The body's microorganisms usually keep Candida in check, but when that balance is upset, Candida gets a chance to multiply. Key contributing factors. A weakened immune system is definitely top of the list. It just can't control the Candida population effectively. Hormonal changes, like we mentioned with pregnancy or maybe oral contraceptives, can also create a more favorable environment for Candida.
And antibiotics, I guess they wipe out the competition.
Exactly. Broad-spectrum antibiotics kill off bacteria that normally compete with Candida for space and nutrients. So Candida takes advantage. Corticosteroids, too, whether they're pills or creams, they dampen the immune response, making it easier for Candida to grow. Diabetes is another major one, especially if blood sugar isn't well controlled. High sugar levels in body fluids basically feed the Candida. Then there are things like poor hygiene, particularly in skin folds, creating moist areas. And even sexual contact can transmit genital candidiasis sometimes.
It's interesting. You mentioned Candida species earlier. Is it always albicans?
Good question. While Candida albicans is definitely the most common, responsible for maybe 90% of infections, both the superficial ones and the invasive ones, it's not the only one. There are actually over 15 Candida species that can cause disease in humans.
Wow, okay.
Yeah. So besides albicans, the other main ones making up that 90% are Candida glabrata, Candida tropicalis, Candida parapsilosis, and Candida krusei. You might encounter these names.
And wasn't there a newer one causing some concern? Candida auris?
Yes, absolutely. Candida auris. It's emerged more recently and is a real public health worry. It can live on the skin, in the urogenital tract, respiratory tract.
Right.
And the issue with C. auris is its potential to cause serious invasive infections, bloodstream infections, candidemia, pericarditis, UTIs, pneumonia. It affects both adults and kids.
And the notes mentioned drug resistance. That sounds problematic.
It is. That's a critical point. Some strains of C. auris, including ones found right here in the UK, are resistant to fluconazole. That's a go-to antifungal drug. So resistance makes treatment much tougher. And while we are seeing this general trend towards more infections from these non-albican species globally, it's still crucial to remember Candida albicans is, overall, the most frequent cause.
Okay, that's clear. So we know what it is. What causes it? Let's talk about who gets it most often. The risk factors.
Right. There are quite a few, and it helps to group them. Big categories include immunosuppression, so HIV/AIDS, organ transplant patients on medication. Diabetes mellitus is a huge one. For women, pregnancy and using oral contraceptives increase risk.
And we've already covered antibiotics and corticosteroids. Those are key too.
Definitely. Then there's obesity, sometimes poor personal hygiene, and wearing clothing that's tight or doesn't breathe well. Traps moisture, you see.
Yeah.
And as we said, sexual activity can be a risk factor for the genital type.
Are there other maybe less obvious risk factors we should keep in mind for revision?
Oh, for sure. Broad-spectrum antibiotics we mentioned. Having medical devices in place like central line, central venous catheters, or getting nutrition through an IV, parenteral nutrition, those can be entry points.
I see.
Certain conditions like Cushing's disease, needing kidney dialysis, renal replacement therapy, having implants like artificial joints, undergoing radiotherapy, being in the ICU, especially on a ventilator for a long time, major GI surgery, even things like iron deficiency or having underlying skin problems like psoriasis or dermatitis.
Wow, it's a long list.
It is. And just general frailty, from things like cancer or malnutrition weakens defenses. Locally, things like heat, moisture, soggy skin maceration using topical steroids, poor dental hygiene, or irritation from dentures all create opportunities for Candida. And finally, the extremes of age, the very young and the very old, are generally more susceptible.
That is incredibly comprehensive. Trying to remember all that for an exam.
Right.
Is there maybe a trick, a mnemonic?
Yes, a mnemonic could definitely help. How about this one? I do a poor hat.
Okay. I do a poor hat. Let's break that down.
Right. I for immunosuppression, D for diabetes, O for oral contraceptives, A for antibiotics, P for pregnancy, O for obesity, another P for poor hygiene, A for age, the extremes, and T for tight clothing.
E do a poor H hat.
Yeah.
Immunosuppression, diabetes, oral contraceptives, antibiotics, pregnancy, obesity, poor hygiene, age, tight clothing. That's actually really helpful. Covers a lot of the big ones.
Glad it helps. It's a good way to anchor the main categories in your mind.
Definitely. Okay, great mnemonic. Now let's shift to the biology. What's actually happening when candidiasis develops? The pathophysiology.
Okay, so fundamentally, it starts with that overgrowth of Candida, usually albicans, in someone who's susceptible because of those risk factors we just listed. Once the Candida starts multiplying beyond normal levels, the yeast cells can change shape. They form these thread-like extensions called hyphae. These hyphae are key because they help Candida form biofilms.
Biofilms, like a protective layer.
Sort of, yeah. Think of it like a sticky, organized community. This biofilm helps the Candida stick to surfaces like the lining of your mouth or vagina, and then actually invade into that tissue.
Right.
And that invasion triggers inflammation. The body reacts, sending inflammatory cells, releasing chemicals. And that's what causes the symptoms we see. The redness, the swelling, the soreness, the itching.
And how does that local invasion turn into the systemic problem we talked about?
That happens mainly in people with weakened immune systems. Their bodies just can't contain the Candida effectively at the local site. So the Candida manages to break through those local defenses, gets into the bloodstream, and once it's there, it can travel anywhere. That's systemic candidiasis.
Oh.
And because it can hit vital organs, it's potentially life-threatening.
Understood. So if you see a patient and you suspect candidiasis based on how things look, What else should be on your mind? What are the differential diagnoses?
That really depends heavily on where the infection seems to be. So if it looks like oral candidiasis, you'd also think about other fungal infections in the mouth, maybe certain bacterial infections, or even some inflammatory conditions of the lining of the mouth.
Right.
If it's in the genital area, especially in women, you need to consider other fungal infections, bacterial vaginosis, various STIs, or even allergic reactions maybe to soaps or something. For skin problems, it could be other fungi like ringworm, bacterial skin infections, contact dermatitis from an allergy, or other inflammatory skin conditions like eczema or psoriasis.
So quite a few possibilities depending on the site.
Exactly. The key is putting together the clinical picture, what the patient tells you, what you see on examination, and then often using lab tests to actually confirm it's Candida and not something else.
Okay, makes sense. Now, epidemiology.
Mhm.
We know it's common, but can we put some more figures on it, especially for the UK?
Yeah, it's definitely common in UK clinical practice.
Yeah.
The exact prevalence numbers do vary quite a bit depending on the type of infection. We know oral candidiasis thrush is much more common in babies, older adults, and anyone immunocompromised. Genital candidiasis is extremely common in women during their reproductive years. While getting precise, up-to-the-minute national stats is tricky, it's something clinicians see very regularly.
And what about just carrying Candida without symptoms? You mentioned that earlier.
Yeah, that's quite striking. Studies suggest up to 60% of healthy people carry Candida species, just as part of their normal flora, causing no harm at all.
Wow.
So actually having symptomatic oral infection is pretty rare in healthy adults, maybe around 5%. But then you look at newborns, it's about 5% there too. But in people with advanced AIDS, it can be as high as 90%. That really shows the immune system's role.
Absolutely. And what about the more serious end, the hospital-acquired invasive infections?
Right. Candidiasis is a major cause of invasive fungal infections in hospitals. Specifically for candidemia, the bloodstream infection, we do have some UK data. For England in 2020, the rate was around 3.5 cases per 100,000 people. And again, just to reiterate that point about the species shifting, we are seeing more of the non-albicans strains causing these invasive infections worldwide, including here.
Right. That's important for treatment considerations down the line. So, let's get practical. Clinical features. How does candidiasis actually present? What should you look for?
Okay, the symptoms really vary by site, but common themes are often itching, redness, maybe some swelling, and frequently you'll see characteristic white patches or some kind of discharge.
Okay.
So for oral candidiasis, the classic sign is those white patches inside the mouth, on the tongue, maybe the cheeks. They often look a bit like cottage cheese and can sometimes be wiped off, leaving a red, slightly sore area underneath. For genital candidiasis in women, typical symptoms are intense vaginal itching, soreness, often a thick white discharge again, often described as cottage cheese-like, and discomfort or even pain during sex.
Right.
And if it becomes systemic, then the symptoms are usually more general fever, chills, just feeling really unwell, malaise. Plus, you might get symptoms specific to whichever organ is affected by the spreading infection.
Okay. And you mentioned earlier there are different types of oral candidiasis. Could you run through those again? That sounds like key revision info.
Yes, absolutely. There are 6 main clinical patterns for oral candidiasis. First is pseudomembranous, which is classic oral thrush. Those white, curd-like patches, common in newborns, denture wearers, people on antibiotics or inhaled steroids, or those with weakened immunity.
Okay, thrush. Got it.
Second, acute erythematous candidiasis. Here, the main feature is marked redness and soreness of the mouth lining. It often follows a course of antibiotics or can occur after a bout of thrush where the white patches have gone but the redness remains.
So red and sore.
Exactly. Third, chronic erythematous candidiasis. This is specifically redness in the area covered by a denture, usually the upper one, often linked to wearing dentures continuously, especially overnight.
Right, denture wearers.
Fourth, chronic plaque-like candidiasis. These are persistent white plaques, often on the cheeks or tongue, that are tougher and don't wipe off easily. More common in smokers, particularly men over 30.
Okay, tougher white patches.
Fifth is median rhomboid glossitis. This looks like a smooth red, sometimes slightly raised, often diamond-shaped area right in the center of the back part of the tongue. It's also linked to smoking or using steroid inhalers.
Red diamond on the tongue. Okay.
And finally, 6 is angular chylitis. This is soreness, redness, and cracking right at the corners of the mouth. It can be caused by Candida, sometimes bacteria, or both. often linked to things like older age, dentures creating folds, nutritional deficiencies, or immunosuppression.
That's a really useful breakdown. Pseudomembranous, acute erythematous, chronic erythematous, chronic plaque-like, median rhomboid glossitis, and angular chylitis. Maybe a visual mnemonic could help there, like picturing a painted mouth.
Oh, I like that. Yeah, you could do that.
So pseudomembranous is like splashes of white paint. Acute erythematous is bright red paint. Chronic erythematous is red paint under the denture. Plaque-like is thick, stubborn white paint. Median rhomboid glossitis is a red diamond painted on the tongue. And angular chylitis is like cracked paint at the corners. Painted mouth. Or maybe PAC. PMA, PAC, PMA. Yeah, or painted mouth, whatever works for you. The visual might stick better.
Okay, great. And for diagnosing these oral types, are swabs helpful usually?
Generally, for straightforward oral candidiasis where the appearance is typical, swabs or blood test serology aren't really needed for the diagnosis itself. The clinical picture is often enough.
Right.
However, you might consider a swab in specific cases. For instance, if treatment isn't working or if you suspect resistance, particularly maybe in an HIV patient with recurrent problems, then a swab for culture and sensitivity testing could be useful.
Okay, that makes sense. So broadening out, again, investigations for candidiasis in general, what's the overall approach? The first step is always a good clinical examination. Looking closely at the affected area, noting the pattern, the type of lesion, combined with the patient's history and symptoms. That's paramount. Then, depending on the site, microscopic examination of a sample can be very helpful. So, scraping a skin lesion or an oral patch, taking a vaginal swab, looking under the microscope can reveal the yeast cells, or those hyphae we talked about.
Okay.
Culture is often used for confirmation. You send the sample to the lab, they grow it, and confirm it's Candida. Importantly, culture also allows them to identify the species.
Which is important because of those non-albicans types and resistance issues.
Exactly, and that's where newer techniques like molecular methods or antigen detection tests are also coming in. They can be faster or more specific for identifying species, especially in tricky cases or when resistance is a concern.
And for suspected systemic infection.
For suspected systemic candidiasis, blood cultures are absolutely essential. You need to see if Candida is actually circulating in the bloodstream. Imaging tests like CT scans or maybe ultrasounds might also be needed to look for signs of infection in specific organs.
Okay, clear. So we've investigated, we have a diagnosis. How do we manage it? What are the treatments?
Right. Management needs to be tailored. It depends heavily on where the infection is and how severe it is. Is it localized or systemic? For localized infections, skin, mouth, vagina topical treatments are often the first step. So antifungal creams, ointments, pessaries, mouthwashes, lozenges, things that act directly on the affected area.
Okay.
Sometimes an oral tablet like fluconazole might be used even for localized infections, especially if they're extensive or recurrent, like for vaginal candidiasis. For more severe infection, or certainly for systemic candidiasis, you'll need systemic treatment, often starting with intravenous antifungals in hospital.
Yeah, and addressing the underlying causes.
Crucial. Absolutely crucial, especially for recurrent cases. Is their diabetes poorly controlled? Do they need to improve their denture hygiene? Can their medication be adjusted? You have to look at the whole picture. And basic hygiene measures, keeping skin folds dry, lifestyle changes, they all play a role in prevention too.
Can you give some specific drug examples for common scenarios?
Sure. For skin and vaginal infections, topical azoles like clotrimazole or miconazole are very common over-the-counter and prescription options. Oral fluconazole, often just a single dose, is very frequently used for vaginal yeast infections.
Right.
For oral thrush, topical nystatin suspension or miconazole oral gel are common first-line choices. If it's more severe or doesn't respond, oral fluconazole may be used.
Okay.
For systemic infections, the big guns come out. Intravenous agents like echinocandins, that's caspofungin or micafungin, or IV fluconazole, or sometimes amphotericin B, depending on the species, the severity, and the patient. Specialist advice is often needed here.
And hospital admission.
Definitely indicated if someone has severe symptoms suggesting systemic involvement, or if they can't tolerate oral treatment, or if they're very unwell.
Got it. And preventative advice is key too, isn't it?
Absolutely. For people using steroid inhalers, reinforcing good technique, rinsing the mouth after use, using a spacer device can really reduce the risk of oral thrush. For denture wearers, meticulous cleaning, taking them out overnight. And for smokers with oral candidiasis, offering smoking cessation advice is important.
Great practical points. So looking at the bigger picture, what's the usual outcome? Prognosis, and what are the potential complications if things don't go well?
Generally, the prognosis for candidiasis, especially the localized types, is good if it's treated properly and promptly. Most cases clear up without long-term issues.
That's reassuring.
It is. However, recurrence can be a problem. It can become chronic, particularly in people with ongoing risk factors like persistent immunosuppression. That can really impact quality of life dealing with symptoms constantly.
Yeah, I can imagine.
And the main serious complication, as we've discussed, is progression to invasive or systemic candidiasis. That's where the real danger lies, potentially affecting major organs and becoming life-threatening. But again, prompt diagnosis and the right management drastically reduce the chances of that happening.
Okay, so early detection and treatment are key. That's a vital take-home message for revision. And thinking about the future, you mentioned increasing resistance in some Candida species.
Yeah.
It does make you wonder, doesn't it? What role might new diagnostics or therapies play down the line? That's definitely something for us all to keep an eye on.
Absolutely. It's a dynamic field. Research into faster diagnostics, new antifungal agents, maybe even immunotherapies. It's all ongoing and really important.
Well, that feels like a very thorough deep dive into candidiasis. We've gone from the definition and causes right through to management and prognosis. Hopefully that's giving you a really solid, high-yield overview to help with your MSRA revision.
We certainly hope it's been useful. Thanks for joining us and digging into this topic.
Yes, thank you. And remember, if you're looking for more MSRA revision resources, do check out pastmsra.com and also freemsra.com. Until next time, keep learning.